Welcome to my YouTube channel. In this video, we discuss about gastrointestinal infection, part 1, Clostridium difficile infection. Did you know that a simple course of antibiotics could sometimes lead to a dangerous gut infection? Meet Clostridium difficile, a powerful bacterium that turns your gut into a war zone. It is one of the most causes of hospital-acquired diarrhea and can even be life-threatening. In today's video, we'll explore how Clostridium difficile causes gastrointestinal infection, its symptoms, risk factors, and why it's becoming a growing concern in modern medicine. Stay tuned. Most important virulence factor of the Clostridium difficile are two toxins, toxin A and toxin B. These toxins have three major structural and functional domains. A. The C-terminal domain. This domain participates in binding of the toxin to the eukaryotic cell membrane, and a small hydrophobic region in the middle of pyroteins. This domain be involved in translocation of the toxin into the cytosol. And last part and the most important part, the N-terminal part have enzymatic activity of toxin. These toxins have two main enzymatic activity, glycosyl transferase and glycohydrolyse activity. Toxin A and toxin B, both of them have an enterotoxic activity in animal models, but toxin B much more potent as a cytotoxin than toxin A. Toxin A acts as a powerful chemotoxic agent for human neutrophils. That means when a toxin A attached to membrane of your gut, neutrophils come to infection site very quickly. The cytotoxic action of toxin B involves the polymerization of filamentous actin, causing a destructuring of the cell cytoskeleton and thus a rounding of the cell. But how does toxin B exert his destructive effect? Toxin B through interruption activity of a group of enzymes, the name of GTPase, that involved in actin polymerization and regulation, exert his effect. In this slide, we talk about how toxin can cause a rounding cell. A little earlier, we talked about three major parts of toxin, and we can see these parts in these pictures. A binding region for attaching to the cell, a translocation region for transfer to cytosol, and a catalytic region that have enzymatic activity. In human guts, this part of toxin add a UDP glucose to the threonine 37 region of RHOA proteins that have rules in actin polymerization. When this UDP glucose adds to this protein, causes inactive this protein, so cause actin depolymerization and cytoskeleton disruption. We know that long-term use of broad-spectrum antibiotics can deplete the microbiota, good bacteria, and eventually creating the conditions for difficile infection. In this slide, we want to know which antibiotics can lead to difficile infection if taken long term. We have antibiotic class and association with Clostridium infection. Clindamycin, ampicillin, amoxicillin, cephalosporins like ceftriaxone, ceftazidime, cefixime, fluoroquinolones like ciprofloxacin, levofloxacin, sulfonamides, trimethoprim macrolides, and trimethoprim sulfamethoxazole have raised Clostridium difficile infection if they use for long term. High risk antibiotics are clindamycin, ampicillin, amoxicillin, cephalosporin, and fluoroquinolones. And we have some antibiotic class have very low risk for Clostridium difficile infection like metronidazole, aminoglycoside, rifampin, carbapenems, daptomycin, and tigecycline. In comments, you tell me why these antibiotics have a low risk for Clostridium difficile infection. And now we discuss about clinical manifestation of infection with Clostridium difficile. Diarrhea is most common manifestation caused by Clostridium difficile. Fever present in 28% of patients and leukocytosis in 50% of patients. Leukocytosis means you have a high white blood cell count. White blood cell like neutrophil, macrophage, eosinophil, and blah 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 blah, and abdominal pain present in 22% of patients. And about stool in this patient, stool in this patient not very bloody and range from soft and unformed to watery or mucoid inconsistency with a characteristic odor. How is this disease diagnosed? The diagnosis of CDA, Clostridium difficile infection, is based on a combination of clinical criteria. Number 1, diarrhea. In this part, this means 3 or more unformed stools per 24 hours for 2 or more days, with no other recognized cause. Number 2, detection of toxin or A or B in the stool. Detection of toxin producing C. difficile in the stool by nucleic acid amplification testing like PCR, or by culture or visualization of pseudomembrane in the colon. Pseudomembrane in colon create in advanced stage of CDA infection. And NATs, including PCR, are widely used diagnostically and are both rapid and sensitive. However, concern has been raised that PCR may detect colonization with toxigenic C. difficile in patients who have diarrhea for a reason other than CDA. That means may C. difficile colonized in your body, in your colon, but your diarrhea have other reason than C. difficile. That means C. difficile not invade your body yet. And I tell you, PMC, that pseudomembrane colloid, is a more advanced form of the CDA and is visualized at the endoscopy in only 50% of patients with a diarrhea who have a positive stool culture and toxin assay for difficile. Endoscopy is a rapid diagnostic tool in a seriously ill patient with suspected PMC, an acute abdomen, but a negative result in examination does not rule out CDA. Despite the array of tests available for C. difficile and its toxin, no single test has high sensitivity, high specificity, and rapid turnaround. In this picture, we show the pseudomembran colite in colon of patient with CDA infection. Pseudomembrans are very clear in this picture and visualized by endoscopy. And now we discuss about risk factors for recurrent C. difficile infection. Number one, advanced age. In one study, the risk of contracting C. difficile during an outbreak was 10 times as high among persons older than 65 years of age as among younger inpatients. Number two, antibiotics used for non-C. difficile after CDEI diagnosis. Number three, gastric acid suppression. And number four, hypervirulent strains. That means you infected with hypervirulent strains of C. difficile. Number five, severe underlying disease like if you have used corticosteroid or renal insufficiency. Number six, previous CDA severity. And number seven, prolonged hospital stays. And number eight, lack of adaptive immune response to toxin A or B. Clostridium difficile is the main causative agent of the disease. Also, infection with other bacteria can also cause this disease. Other bacteria like Clostridium ramosum, Escherichia coli, type O 157H7, Klebsiella oxytoca, Shigella species, Staphylococcus aureus, Yersinia enterocolitica, Salmonella enterica may cause pseudomembran colites. This video end. I hope you loved it and learned from it. Subscribe to my YouTube channel for more video.